I love the titles of some of these. There's Trauma for Your Mama.
Oh, that was the file name. And the trauma.
Okay. I called this Fix the Problem specifically because every time I came on shift, my preceptor was like, you need to fix the problem. So, and every time I would assess, there was always something wrong. And then I only had like a couple pictures in here. This next one was of a cabbage, specifically because like you can see the left, the left main, the circumflex. That's exactly how I picked it. So, this is Mrs. Chick-fil-A, 67-year-old female. She was 5'6", weight 218. Medical history of hypertension, GERD, hyperlipidemia, and COPD, 1 pack a day smoker. Surgical history of a tonsillectomy and a hysterectomy. So she was out in North Carolina, presented with chest pain and some throat pain. They ruled out NSTEMI, and her heart cath revealed 3-vessel CAD, and she had a good left ventricular function. So they transferred her over here for surgery. Pre-op vitals, 142 over 71, PRs 56, respers 11. So her procedure specifically was a cabbage ×3 LIMA LEVH. Here are some pre-op labs, but I really don't want to go much into that. But let's take a really quick look. As you could tell, her O2 was pretty low, 78. So that was one of my main focuses. So my pathophysiology is very simple. Her lifestyle overall, she was a smoker. Her diet was just really crappy. Led to COPD, her hyperlipidemia, and that's why she also had that angiogram for that 3-vessel disease, which in turn was a coronary artery disease. And that's why she was in the hospital, of course. So before this assessment, really quick story. I was doing my neuro assessments on this patient, and so I came on to the shift, and I learned my lesson here because I was doing my assessments, and I was just like, could you tell me today's date? She wasn't responding, and then I started flashing my light in her eyes. So she really wasn't responding, and I was like, the previous shift was like, oh, she's Perla, she's alert oriented ×4. And then I told my preceptor that, she's not responding. She goes, did you try waking her up? And I was like, oh, makes a lot of sense now. Because she really was asleep. And I was like, oh, okay. So neuro-wise, she was alert-oriented ×4 Perla. Positive grasping reflexes, good plantar flexion. Appropriate movement against gravity. Her pain was moderately controlled with morphine. Cardiovascular-wise, her cardiac indexes were a 2+, but it was like a 1.7 before our shift, but I'll go further into detail with that in a bit. S1, S2 pulses were good, less than 2 sec cap refills. She had a chest tube in place, 2:1 atrium. She was AAI paced with threshold of 7, A sensitivity 0.5. She was, thank God, normal sinus rhythm, pre and post. And her drips, epinephrine, nitro, and insulin. Pulmonary-wise, she was coarse. Again, when she was asleep, I was sitting there listening. I was like, oh my gosh. Yeah, definitely she has some, some ronchi going. And then and I was like, okay, it's different now. Because when I started listening, I was like, okay, cool. So during the day, she was on high flow, 35% and 50. And during night, she was on BiPAP. Her ABGs were variable, and I'll show you that here in a bit. GI hypoactive. She said her appetite was slowly coming back, and she did have a Foley in place, and she did have a urine output of 30 mils, to say the least, because every time we're on shift, we're praying to God that the patient pees. And musculoskeletal I didn't add because she was up. She was able to ambulate with assist. And her skin, she had a midsternotomy with a CT dressing and also a leavings to the coccyx. Okay, so I put this up here specifically because her cardiac index during the day shift was a 1.75 because that's when they tried to titrate I think it was epi and the nitro. So they shot an index. It was a 1.75, and then they restarted her on her epi and nitro again. And at the end of at the end of the nurse's shift, she was like, "Okay, I turned off the nitro." And then I was like, "Oh man, let me shoot an index." And what came up was her SBRI was increased, and I was like, "Man, here's another problem I gotta fix." So I'm thinking of drugs that I should recommend to the doctor, and I had no clue what drug I should recommend to the doctor. So not to the doctor, the PA. So I spoke with my preceptor, and she was like, a good drug for afterload after you titrate nitro would be hydralazine. So, like, yeah. And then we, as you could tell, we gave her hydralazine, and her SBR started to drop at 11, and at 1, her cardiac index was perfect. Okay, you don't have to look at the ABGs, but her ABGs were just overall, they were bad. That's all you have to know. So here's what it looked like, her x-rays pre-op. It was pretty clear, but then she had some atelectasis post-op, specifically because she wasn't using her IS or her coronet. Let's not go. So basically, here's what I did for her. For her respirers, her ABGs were showing a PO2 at 62 while on high flow nasal cannula, and she was a bit tachypnic, so she did have some impaired gas exchange. So I started doing some further investigation, and that's why we tried to titrate the nitro, is because we felt like there was some shunting involved, and we did titrate that. So, and we put her on a, what's it called, a BiPAP. So she did show improvement until, the next day. Of course, they were like, let's put her back on, what's it called, a high flow. So during day shift, they messed up my ABGs, but it was okay during my shift. ABP, her mean, my main focus for her was her mean specifically to be above 65 while we titrate the epi and the nitro. Her cardiac index is, of course, above a 2.0. So she did have some decreased cardiac output because of that. I think what they did was they didn't titrate the epi. I think it was like at 2. And I don't know who the nurse was. They specifically just turned it off. And I was like, man, thank you. More problems. And pain rating, that was like one thing that I wanted to get under control, specifically because when you are in pain, you are clamping down, so your blood pressure rises. So again, started on a BiPAP, weaned off the epi and the nitro, started her on hydralazine, which dropped her her MAPS, and we did have vasopressin just in case to increase her MAPS, just in case we needed it. And for her pain control, we used morphine. And with morphine, you would see a decrease in blood pressure, and also her respirations would, what was it? I forgot what I'm looking for. The word I'm looking for. Alleviate pain. But all my goals were met. She states that her respirations were better. They were a little bit more shallow. She did get some sleep. Her ABGs they did get better. Blood pressure control, that was met. Weaned off epi and nitro. We did have that hydralazine, and we did restart her on her home medication of metoprolol. And it was funny because the doctor was like, let's start her on some metoprolol, and I was like, well, she is on epi and that's contraindicated. And then Rebecca kind of just looked at me like, just give it anyways. And I was like, okay, let me ask my preceptor because I'm not going to give it while she's on epi. And her acute pain, we did meet that. We just kept giving her morphine, and we started to go the oral route with Roxy and Percocet. So overall, to paint a bigger picture, we had to control not only her pain, but also her nitro. We had to titrate, so therefore there would be no shunting, and get her on some hydralazine PRN and get her back on her metoprolol, which we did fix.